Hello, and welcome to Individualized Learning and Resident Assessment, a CBME orientation for residents. This is the seventh installment of this webinar series focused on navigating the shift to competency-based medical education, brought to you by STFM and the AFMRD. Today's webinar features two members of the STFM CBME Task Force, Dr. Maggie Curran, a third-year family medicine resident at the University of Kansas Medical Center who will be staying on as faculty after graduation, and Dr. Olivia Rae Wright, associate professor at the University of Washington. During this webinar, please utilize the Q&A feature to ask questions of the panelists. Although you may ask questions at any time, designated time has been set aside to answer your questions toward the end of the presentation. We hope to see you at the next webinar, How to Have Reflective Feedback Conversations and Develop a Culture of Effective Feedback, on July 10th. You may register for this webinar and access the previous webinars in this series at stfm.org/CBME webinars. Now, Dr. Curran will begin today's presentation.
Thank you all for joining us, both live and those watching the recording afterwards. We're very excited to share with you this resident perspective of CBME today. A quick review of our objectives. By the end of our session, we are hopeful that our residents will be able to describe what CBME is, embrace the culture of feedback that is so integral to the success of CBME, address outcomes and how we can use those to build and implement individualized learning plans, and then effectively engage in program improvement and development as this is all implemented. So the big question, what are the goals of CBME? A big core tenet of this is really access to quality care for our communities. We know that healthcare outcomes in the United States have been declining, and so the goal of CBME is to do a needs assessment, really evaluate what our communities need so that we can train residents and future physicians to best serve our communities. With that comes developing adaptable family physicians. And so we know that by providing our residents autonomy, by engaging them in their learning experience, we can create specific goals for where they view themselves and where we view ourselves practicing in the future after their residency experience. And so the hope is that by doing these community needs assessments, by having ownership and autonomy of our education, of our learning goals, we'll be able to improve our workforce by developing and graduating residents and physicians that are competent and best suited to serve the communities that they're based in. So there are 5 core components of CBME. The first one is that this is an outcomes-based framework, and later we'll review the 15 core outcomes that are going to be so important to the implementation of all of this, but that really is kind of the heart and soul of what CBME is. And this has to do with progressive sequencing. So recognizing that we have to meet some outcomes and gain some competencies before we can progress on to the next ones. And learning experiences within CBME are obviously competency-based. So we're moving away from certain numbers of procedures or a certain amount of time and situations and recognizing that this is learner dependent. Some people may reach competencies quicker or slower than others, and that is okay, and that is expected. And so we're going to tailor our teaching and experiences to these competencies. So we're really responding directly to our needs as learners. Where are our strengths, where are our weaknesses, and where can we find those areas for growth? And then lastly, that's where we find that programmatic assessment and making sure that it's effective. So using methods like direct observation and finding new innovative ways to provide feedback so that we can continue to progress towards these outcomes. And these outcomes are really based on 2 things. One being the societal needs, and then working towards graduating these effective health professionals specific to the communities that they'll be based in. So that's what went into the thought process behind the development of these outcomes. We wanted to make sure we're developing quality and competent graduates that are going to be able to meet the needs of society as a whole, but also the specific communities that they find themselves in right after graduation, but also that may change in the future, and making sure they're prepared for that as well. So we have a quick poll before we review these outcomes. Our question is, what do you currently know about these outcomes and what's your familiarity with them? Okay, so it looks like the majority of our viewers have heard of these 15 outcomes, or maybe starting to hear more and be more familiar with those first 5 outcomes. But we also have a good portion of people that know they exist and we don't know what much else about them, which is definitely where, as a resident, I felt like I was several months ago. So we're going to kind of dive into what these outcomes are and what that rollout process looks like. So the ABFM has developed these 15 outcomes with the goal of our program directors eventually attesting that we are competent in all 15 of these areas. However, we know that this is a change and that can be really difficult for residents to figure out how are we going to be evaluated, how are we going to be assessed that we are competent in these areas. So the plan is for a phased rollout over the next 3 years. We'll be having 5 outcomes that will be kind of added to our list that will be our program directors will be attesting to. This is bound to be a very collaborative process, both with residents and programs, but with the ABFM as well, because the hope is that the CCCs will look at our feedback as residents, our program director will look at all the information they have about us and ultimately be able to attest that we have met these. Obviously, if our program directors can't attest that we meet these outcomes, then there would be a reevaluation of, do we need additional experiences? Do we need additional time in our training to be able to ultimately meet these competencies? And what can we do to tailor our education in order to do so? So these first 5 that we're rolling out were felt to be really kind of the core pillars of a family medicine physician. Felt to be, if we didn't have these, we really can't move on to the more specific and a little bit more vague or kind of more elusive outcomes. And so these really dealt with communication, they dealt with teamwork and things like that. So we have the outcomes related to developing relationships, not only with patients, but with our teams and our colleagues. We're developing skills in doing patient-centered care, making sure we're doing comprehensive primary care, getting that continuity care experience, but also being able to see people in the acute illness and injury setting, whether that be in the emergency room or in the hospital. And then we know as family physicians, caring for children is a big piece of what we do too. And so making sure that we get experiences, not only with those well-child checks, but caring for them in urgent and emergent settings as well. And then really knowing that as physicians, we are supposed to be professionals and we are meant to be kind of leaders in those settings. And so are we modeling that, and how can we best exhibit those skills? The next outcomes that will roll out in 2025 start to get a little bit more specific. So looking at things like preventive care, looking at things like teamwork, and also more of our specialized care that we tend to provide as family physicians. And so looking at are we competent in providing sports medicine care, musculoskeletal care? Are we adept at providing preventative care, whether that being risk factor adjustment, cancer screenings, identifying illnesses and things like that, assessing priorities of care, identifying sick versus not sick. How do we balance our patients' desires for that clinic with what we deem as kind of most important in that setting? And then really getting comfortable with that undifferentiated patient walking through the door. How do we balance that acute need with what their comorbidities are? And then lastly, making sure that we're getting experience and confidence in leading and participating in medical teams, especially those multidisciplinary teams. And then the last competencies that the plan is to, or the last outcomes, sorry, that the plan is to roll out are a little bit more complicated to assess. And so we wanted to really make sure that programs and residents had time to get comfortable with what does assessment of these outcomes look like and how can we be successful in that. And so these are things like taking care of women, the elderly, end-of-life care, and knowing when to engage our specialist colleagues and when that is appropriate. Providing low risk pregnancy care, postpartum care, regardless of if we as residents decide to practice labor and delivery care in the future. Getting comfortable with mental health conditions and treatment and management of that. Getting access to those procedural experiences and gaining that competency and confidence in doing those. And then lastly, that kind of core component of CBME in general, that lifelong learning and self-reflection that's so important to really that education of a family physician. And so Dr. Wright is going to talk a lot more about how we will evaluate these things and assess them.
Thank you so much, Maggie. So Maggie, I think, did an amazing job of pointing out what the outcomes are. But I thought it might be useful to give a little bit of a history about where they came from. So some of you may have heard of something called Entrustable Professional Activities, or EPAs. And if you have those in your program, it doesn't mean that you can't use them anymore, but the outcomes have sort of replaced those, at least from an official point of view, that programs, the requirements, what they're going to have to trust you in to be able to do when you graduate are called outcomes. And so if you're wondering how that ties into all the other stuff that you're supposed to be doing, related to milestones and competencies, we're going to go through that a little bit. So take a little history tour. So 20 years ago, residency programs had required rotations, but they didn't really have it organized in any particular way. And that's when ACGME first came out with the 6 competencies. The 6 competencies are patient care, medical knowledge, interpersonal and communication skills, professionalism, systems-based practice, and practice-based learning and improvement. So those first 2, the medical knowledge and patient care, I think everyone thought of those as core all along, but what teachers of family medicine and not only family medicine, but all residency programs have these competencies now. What they realized is you can't be an effective physician if you don't also practice professionalism and have those good interpersonal communication skills, and all of those other things. So really the 6 competencies were just a way to organize all the work that we already do that makes us really good at what we do. And then about 10 years after that, programs were still sort of trying to figure out more about, now, what are we supposed to really be doing with each of these 6 competencies? They seem kind of vague. And so ACGME, in their wisdom, decided to break these down into subcompetencies. And each specialty has their own set of subcompetencies that's specific to them, and as does family medicine, which I think may have the most of anyone, which kind of makes sense. And the subcompetencies are really just breakdown of the categories of the 6 competencies, and then the milestones were labeled on top of that. So the milestones that are within each of those subcompetencies are really meant to be the activities that you do all through residency. The categories are the competencies and the subcompetencies, but the actual activities that you're doing from day one are now organized in that same way, and they're further organized by levels, as you know, and those levels are meant to be part of that progression that Maggie talked about, where you're learning a little bit at a time and building on that. So then what do the outcomes have to do with all that? So the outcomes were really there all along. They just hadn't been codified by ACGME and now ABFM. So in order to graduate, you have to complete a residency program. But in order to be board certified, in addition to that, the residency program has to say that you are competent to independently do those 15 outcomes that Maggie shared with you. The outcomes are meant to be what you do at the very end. So these are your goals. All through residency, you're meant to plan out what you can do to meet those 15 outcomes, and using the milestones and all those skills within that to help meet that. And I think this will become more clear as we go along. But the outcomes aren't replacing anything. They're just clarifying why we have all of these competencies and milestones and what the end result of being successfully completing all those will look like. So Maggie also talked a little bit about progressive sequencing. And so again, the milestones are part of that. But the real core of this is the idea of being individualized. So all of you come to your programs with a different set of skills. You went to different medical schools, you had different rotations, you have different life experience, and you have different personality types. And all of that, as you know, from day one, changes what you're able to do. And if we don't recognize that from the beginning and think that everybody has to be the same in every part, then we really miss opportunities to help you play to your strengths, opportunities to recognize areas where you haven't had as much experience and find ways to give that. One of the ways that we are meant to be able to provide that extra experience for those who need it, people who are just struggling a little bit in one area or just didn't have enough of it when beforehand is all this extra elective time. So the extra elective time that ACGME required as of last year was really not just to help develop specific skills or niches that you're interested in. And they can certainly serve part of that purpose. But the primary reason the extra elective time is to give individuals opportunities to do extra work in the areas not only that they're interested in, but in the areas that they're struggling at so that they can become competent in those outcomes. And of course, it's not always a smooth curve. Sometimes you feel like you got it, and it's very frustrating when you feel like you've taken a step back, but that's normal. Everyone does that. And a lot of times it's just your patient panel became more complex or something along those lines. And that's okay. It's meant to be a two-way conversation between you and the program so that you can develop in this progressive way. So how do we help do that? How do we help drive the opportunities for residents to get the experience they need? Part of it is getting away from too many required numbers or too much required time. And ACGME, again, helped us with that. They changed some of those requirements in the last 2 years. For those of you who are new residents, you may not have realized that, but it is a change. So a lot of the programs, you'll need to give them a little grace because they're still adapting to the changes that are required by ACGME. The reason they're doing that is to give that flexibility for individual progression so that there are going to be some residents who need to do more of a particular procedure or see more of a particular kind of patient than another resident. And so building that kind of flexibility into the curriculum is a goal of programs, but it's new. And so they're going to be working on it a little bit. And again, the idea is to tie all of this to our ability to trust our graduates, which will be you, to go out and practice medicine and all do it in a way that meets those graduation targets or outcomes. So how do we update our curriculum to do that? We talked about the experiences. The other thing that's a big part of faculty development going forward for your faculty is coaching. So some, as you know, some of your faculty are much better at giving you feedback than other faculty. Sometimes it just is, it seems vague. They say, good job, or you need to work on this. But they need to be very specific about what that is and to be able to help you identify your own goals that are specific to your learning needs and to work with you on that. It is meant to be a joint effort. So your faculty are learning and you need to help them in that process. So you need to be actively engaged. And that's where your individual learning plans come in again. It's you thinking always about where am I on my trajectory? How do I get to where I need to be at the end of this? And how can the program support me in that? So all of that is really the core, but part of the next step is for us to be able to assess where you are. Self-assessment is part of that and is really important, but it's not the only thing. Your faculty have been doing this for a long time, and they're specially trained to be able to do this kind of assessment and to give you advice about where you are in your path so that you can make the right choices when you're updating your ILPs or choosing your next elective experience. So to make this a really healthy, meaningful assessment system, it needs to have a lot of it. There needs to be multiple points and multiple methods. And what I mean by that is you need to have a lot of different evaluators to minimize bias. You need to have it done by different kinds of assessment tools. Not every tool suits the person or suits the rotation that you're on. And it needs to be done in a bunch of different settings with a bunch of different kinds of patients. It also needs to be timely and meaningful. So when I say timely, I mean at the point of care whenever possible. And that's not always possible, but we can do better. And so programs are working on strategies so that they can give you more of this meaningful feedback that's very specific, so you know exactly what they're talking about so that you can work on it at the point of care. And then the system for decision-making is really where the CCC is going to talk about how you're progressing to the next level of your training. So the assessment system needs to be able to give all that feedback to you So you know what's happening so that at the end of the year or at the end of the semester, there are no surprises. The worst thing that can happen is for a resident to be just caught off guard, and that's not good for anyone. You need to know where you stand and so that you can improve in a timely way. So we talked a lot about entrustment, and I thought it would be worth reviewing what we mean by entrustment when we're talking about assessment. So this is what's called an entrustment scale. And this is what you will likely see more of on your evaluations in the future. It's trying to get away from things like Likert scales. Likert scales are basically how good to how bad you're doing something. And that just makes people feel bad and doesn't really give meaningful feedback. Entrustment skills have been shown, and they've been used in Canada really extensively, and evidence so far has shown that they're decreased bias and that they're more reliable. And it starts with, say, at the beginning of residency, if we're talking about something like a pap smear and you've never even seen a pap smear for whatever reason, then that's okay. That's where you are, and we're going to help you get to where you need to be. But it means the first time you do it, the faculty is probably going to let you observe, and they're going to record that. So the next time that you're in clinic, the next faculty will recognize, oh wow, they just saw their first one, so now they can probably do it, but they're going to need a lot of assistance. And then you're going to grow continuously. So the idea is that there are going to be some things you may have done a lot of, maybe pap smears in medical school. You did a GYN rotation and that's all you did every day. And so you're going to be able to perform these independently from the beginning, or you're someone who really didn't have that kind of experience. And so we're going to help you get there. And this scale is meant so that we can all look at it in the same way. And it's really just about your ability to do it independently. So competency-based assessment as our future. So we talked about more frequent evaluations at multiple points and multiple methods. We talked about it being more formative and less summative. And what I mean by that is that formative is the feedback. It's the feedback you're getting in the moment. And it's meant to be not just one way. That's meant to be bi-directional feedback, meaning that the attending will give you feedback and you are supposed to ask clarifying questions and talk about what you felt about the visit and make sure that you can explain why you're doing what you're doing. And more importantly, ask how you can do it differently next time to meet the expectations for competence in that. And get away from just relying on summative evaluations like at the end of a rotation. And it's going to start by modifying a lot of your evaluation tools. You'll start to see that entrustment scale showing up on new scales, and the questions will change a little bit and be more directed so that the CCC can help see where you are on that journey towards being competent in those outcomes. And then at the end of this journey, of course, is that the program director needs to be able to report this to the ABFM. So Maggie alluded to the fact that we need more direct observation. So let's talk about that. Why do we need more direct observation? And why are we going to be pushing for that so much going forward with residency programs? Well, the ACGME and ABFM have both agreed that work-based assessments are the most important. And that comes from something called Miller's Pyramid. And this is in the middle of the slide is what Miller's Pyramid looks like. The thought is at the beginning of the pyramid, in your journey towards being a competent physician, or really in any sort of outcome, that it's about knowing things. So that was a lot of medical school, right? You're taking multiple choice tests, you're doing a lot of learning and memorizing and applying it to case scenarios. And then you start to get out of that a little bit when you get more into your clinical rotations, or as your clinical rotations, if you're in a program that starts out earlier in the process, they get more intense and you get more responsibility. So as you move up the pyramid, you go from knows to knows how, where you can do those vignettes, to shows how, which might be demonstrating with an OSCE or an oral exam. And maybe that's how you start out in residency. Part of orientation, you may have some OSCEs. You're doing simulations when you take ACLS, that sort of thing. But the rest of residency is really about doing stuff. And the only way for faculty to know if you're doing it correctly, if you're doing it competently, if you're able to do it without supervision, is to watch you do as much as possible and give you feedback on what they saw. So that's where that's coming from. So why else do we want more direct observation? Well, it mitigates bias. It takes out that sort of a assumption part of an evaluation where you're assuming based on precepting what happened in the room. Often that looks very different than when you're actually watching what happened in the room or what the communication looked like. And so that's one of the big advantages of direct observation. It's also, given that those multiple settings, multiple observations, more reliable, it leads to opportunities for improvement earlier than this. And then effective feedback in the moment is going to be your key to success. So asking for feedback, being very absorbing that as much as you can, and helping your faculty get better at it. Making sure keep their feet to the fire, that they're giving you feedback that you can make use of. So another way to look at, we talked about Miller's pyramid, and then this is another pyramid that's kind of the top of that. So if we say the top of Miller's pyramid is about doing stuff, this is what the evaluation process should look like within that. It would start mostly with the feedback that you get all the time already. Every time you precept with a faculty, you see a patient in the inpatient setting, whatever you're doing, you're probably constantly getting feedback in the moment. And so that's great. You need that feedback, and it's based on what they're seeing you do. But then what we're going to have to do a lot more of at this next level is documenting this feedback. So it's the same thing that's been happening, but there are going to be some specific opportunities where direct observation leads to an assessment that's documented and hopefully discussed at the same time. The next level of feedback is really this end of day sort of feedback. Some people call these shift cards. It's kind of a mixture of formative feedback and summative, where you're summarizing how the day went, but it's still really close to when you did it. So the feedback will, again, be more meaningful because you'll know what the heck the faculty is talking about. And then really a smaller part of this process should be those end of rotation evaluations. And they should never be surprises. They should really just be a collection of all that feedback you've been getting, so that your end of rotation shows how you've been progressing, and talks about the things that you've been getting feedback on all along. And then that same process is where the semi-annual evaluation comes from. And so that's when the CCC meets and goes through the milestones, and then you'll meet with your advisor or another faculty to go through those. And these also are more summative, but should never be a surprise. And then finally, this is your final evaluation will be the one the program director does, that takes all this into account with recommendations from the CCC, that you're ready in those 15 outcomes to practice medicine independently without supervision. So here's another poll, and then I'll transition it back to Maggie. So how often are you currently observed by faculty when seeing a patient? So having that direct observation. Okay. So it sounds like most of you are currently getting most of your direct observation tied to procedures, which I think has been my experience working with the programs affiliated with the University of Washington as well. That you may get a lot of direct observation, but it's not usually documented. Again, I think that's pretty true for all programs. And then that And about 20% of you are getting it pretty often and already getting some of that documented. So that's great. But I think nobody said too much. So thank you. I'm so excited that you say that, because this is where we're going in the future. Okay, Maggie, I'll turn it over to you now.
Great. So I think kind of going off of that, there's sometimes the question of, how much feedback is necessary to gain these competencies? Is there some magic number or a threshold that if we get this amount of evaluations, we'll be ready to be competent? And that's not necessarily true, but we do know that the more data points we get, the more likelihood we're going to be able to get actionable feedback that will best prepare us to be competent physicians. And so the ABFM created an assessment that showed us that the median resident has about 50 to 75 assessments at the time of graduation. If we compare this to our colleagues in Canada who are doing fantastic things with these, their residents are graduating with 1,500 data points in regards to feedback, which feels astronomical at times. And that doesn't mean that it's all great feedback or all actionable, but we do know that the more data points we can provide our residents, the more likelihood we are to get key tools and key steps and recommendations for us to add into our day-to-day practice to continue moving towards reaching those outcomes. And so this has been touched on some, but the proposed rollout for all of this is that the ACGME has really given us the tools to roll this out by creating these new program requirements that are really based in outcomes and competencies. And so the role of the program director and all of that is at the time of graduation, creating that attestation for each individual resident saying, yes, we are competent in those outcomes and you are prepared for graduation. The ABFM roles in this is that once they receive that attestation from the program director, it needs to be in regards to all 15 of those outcomes. So we discussed the rollout, and so over the next 3 years, it will be 5, 10, and then all 15. But in order to be board eligible and to become a board certified family physician, your program director will have had to attest that you are competent in all 15 of those outcomes. And so then that, going along with that, our readiness for board eligibility, in addition to those 15 competencies that we've been attested on by our program director, we're continuing to get those 40 weeks of continuity in our clinics, 1,000 hours of continuity care, but then some of those other measures of our competencies and readiness to practice independently, which is that continuity experience, those referral rates and things like that. And so it's really this full package that will attest to that we are eligible to be board certified. So change is really hard. And I think change is really hard as a resident because our life changes, month to month between rotations, but day to day. And so things like this can be really overwhelming. And so it's important to know that there is some awareness of the barriers that come with implementing CBME. One of those is this acceptance of more direct observation. Like we saw in the poll, this is not necessarily something that's happening regularly for a lot of residents. And so it may change what our day-to-day looks like in clinic or on inpatient, because you have to really plan to have somebody come in the room with you and to create time not only for that, but for that feedback that comes afterwards. And so recognizing that this is will take time to change, and it may feel overwhelming or it may feel uncomfortable as we're implementing it, but there's a really important reason we're doing it. Because with that, we start to get more of this curricular flexibility. If your faculty are seeing that you are competent in some areas or have room for growth in other areas, it allows you to really tailor that elective time, maybe to get even move above and beyond in certain areas or get those extra opportunities because you've met an outcome already, or you're really close to meeting that outcome, or developing an elective that is an area you maybe need a little bit more time on and have identified as an area for growth for you. And in order to do that, it really takes shared expectations. So that open line of communication between us as residents and with our faculty, and sharing what we feel are our areas that we need improvement on, but also listening to what they're saying and vice versa. So knowing that we get to share those that feedback with our faculty as well, and share what's working and what's not working and how can we improve that. And like it was mentioned, the goal of this is that there's no surprises. The goal of more frequent feedback and more direct observation is that you know where you're tracking the entire time you are a resident. So you're not making it to the end of first year, second year, or graduation, recognizing that you are maybe behind in one competency and are not set up for success to graduate. And so the goal is that you really have that support all 3 years to be meeting those competencies at the time of graduation. And all of this revolves around resident and faculty engagement, those very strong relationships, whether it be with your program director, your coach, your advisor, and really making sure that you're staying engaged along this process, taking the time to review that observation feedback, taking time to review other modes of feedback that you're getting, and then providing that feedback and discussing that feedback with those faculty members as well. So what are the next steps? How can we as residents, how can programs set up residents for success? The first part of this is really integrating these new resources and tools. There's lots of new things that are coming out. We've got the toolkit, we've got these webinars, we've got lots of ways that residents and people can start to get exposure to these things that will be starting to be a part of their day-to-day experience. But in order to integrate those, I think the most important thing is that we need this shared development between residents and faculty, because we all really need to understand the why. Why is CBME so important? Why do we think that this is the next best step for medical education? And then once we understand why we're doing it, how do we implement it and how do we make it successful? And that's where that time piece is such an important pillar of this implementation as well, whether it's time during resident orientation, time during resident didactics, time for faculty development. We know that everybody's going to need time to really understand how this all works and how they can use it to set themselves and their colleagues up for success. Specifically as residents, we really do have to embrace this feedback culture. We know, I know that feedback fatigue is a very real thing, especially when you're not getting quality and effective feedback. And so knowing that there's going to be a lot going on behind the scenes of training faculty and faculty development to make sure that the feedback we are getting, that direct observation we are getting, is hopefully going to become more and more effective as people get more comfortable with this. But because it's a feedback culture, we also get to be an active participant in it. We get to provide that bi-directional feedback. If you have faculty members that are providing feedback that maybe is harder to implement, or maybe you have questions about, you get to ask those questions. You really get to be an owner of your learning experience, which I think is so important. But with all of that being said, there is a lot of grace that needs to come into this process, and recognizing that our faculty, our administrators are learning new tools, they're learning new feedback apps and things like that to will hopefully be successful one day, but it's a change and it's something that takes time. And so there may be pieces that work better than others at the beginning, but we know that people are trying and working really hard to set us all up for success. And with that, being open to those new tools. So being open to those direct observation experiences, being open to new feedback templates that maybe your program is rolling out, being open to those more frequent touch points, whether it be at the end of a patient encounter, at the end of a clinic day, at the end of a hospital week, just knowing that that we need to be open to those experiences, because ultimately it'll make this rollout a little bit more smooth. And then through all of it, thinking about, we just talked about these 15 outcomes. We know what we're working towards by the time we graduate. So how can we reflect on those? How can we look inward and then apply those to our individualized learning plans? So we've talked about ILPs a lot. I think this is a term that gets thrown around and means a little something different to, I think, each person in each program. And so the hope of CBME and some of the tools we're providing is that we can standardize these experiences a little bit more to make sure that each resident is getting the most out of their ILP as possible. So the heart and soul of an ILP is really self-directed learning. It's looking inward, identifying your strengths, identifying areas for growth, and putting those on paper and really planning for the future. This is something that's meant for all residents, not residents that are maybe just struggling in certain areas, not residents that are ahead in certain areas, but really for every single one of us, we should be able to look inward and create a plan that's best for us. And because of that, it's driven by what our goals are. It's looking 3, 5, 10 years in the future and identifying what our career goals are and how can we build an educational experience during our residency to set us up for success there. So as you identify those goals, as you identify the steps to reach those outcomes, how can I look at the feedback from my program? How can I have conversations with my coaches to incorporate that and create concrete steps to reach those goals? And so I get to draft it, I get to develop that, do that self-assessment, and then I get to go to my coach and sit down and share what my thoughts are and have that conversation to hear what they think in regards to my self-reflection, to hear how they think I could implement more feedback or tailor things in an individual way, and really prioritize, here's what they could see being a more effective way to reach some of those goals. But it's really this bi-directional conversation where we get to be in the driver's seat. And so like it was touched on, the ACGME has really, I think, set us up for success in regards to implementing all of this. They've created these program requirements that are now required by every program that are really the heart and soul of CBME. And so recognizing that there are requirements in regards to serving the needs of the community and coming up with those distinct capabilities and abilities they want their residents and their graduates to have to best serve the communities that they're in, specifically in regards to these competency-based goals. And so we know that transitioning to this, your participation in the CBME experience and the feedback and the ILPs, it really is the learning experience. And so we know that working towards the CBME will help us reach those outcomes, and we'll get even more time dedicated to our individualized education that we now get to have, I would say, more ownership of participating in those frequent assessments and evaluations.
All right, so we're near the end. I have been keeping an eye on the Q&A, and there aren't a lot of questions yet, but we are going to have plenty of time to take questions. So if you have anything for either of us, please add it to the Q&A. So in closing, we just want to break this down into language that hopefully everyone can sort of wrap their brain around. And it's really about 4 major categories when we're talking about CBME. It's about curriculum updates that allow more flexibility with electives and target the outcomes. It's about assessment strategies that allow us to have a lot more assessments that are done reliably by giving feedback with direct observation. It's about making sure that we have faculty who can act as coaches to focus on your individual learner needs and help you develop those specific, measurable, achievable, relevant, and time-based objectives. And it's about you, the residents, being engaged in the process and primarily focusing on your ILPs, but also giving feedback to the faculty and to the program so that we can improve. And we're all in this together. When you do well, we do well, and we all live happily ever after. That's my theory. So thank you so much for listening to us today. And as I said, we would really love to answer any questions you might have. Okay, so we'll start with the ones we do have. The first question is regarding the ABFM website and the outcomes. And one of our participants said that their director had printed out the outcomes, but they were in a slightly different order, and wanted to clarify that. So thank you very much for that question. The answer is that the original outcomes had the communication outcome at the beginning, and then later moved it to number 4, but it's still the same in terms of being in the top 5. So yes, you are correct. The communication outcome is actually number 4 and not number 1, but the 15 outcomes otherwise are the same. And the next question was, in the case of a resident who has significant challenges with procedures, but you know that they are going to do a fellowship that does not include, but you know that they're going to do a fellowship such as palliative care that won't require procedures, can you not attest to an outcome focused on procedures? Would that preclude them from being board certified? So the answer to that is really 2 parts. So the first part is that each program has a list of required procedures. And so all residents, in order to graduate successfully from the program, will have to do the procedures that you have said from the beginning are required. So you might want to alter your list if there are certain procedures you don't think somebody going into a fellowship would need. That being said, I am told that ABFM is going to come up with a list of these required procedures in the next 2 years. And at that time, then it'll be a focus on those in order to answer that question more specifically. Hope that answers that. And the next question, for those who have been doing direct observation, how many and how often do you do this for each resident? How do you find time for preceptors to do that while they are precepting 3 or more learners? So I'll start with answering that, but then I want Maggie's perspective on that from the other direction. So the programs that were piloting this initially have the recommendation was to do 1 per week per resident. So the other part of that is that the direct observation does not need to be an entire encounter. So you don't need to watch a resident do a visit from start to finish. You can just watch the first 5 minutes of their history taking and then give them feedback that's documented about how they take a history, or on the other end, how they give patient instructions, or maybe you just watched part of an exam for a patient who came in with the knee pain, maybe you watched the knee exam. And so really these little snapshots of direct observation are what we're talking about, not entire encounters. So I think that will help with a lot of that issue. And then the next question is, there was another one down the list on the list of outcomes that was in a different place. Whatever the list is on the STFM website is the official list. So please refer to that list for the official answer. Maggie, I wanted to come back to you. What are your thoughts about how to get more direct observation from a resident's perspective, of which you are for 2 more days, I think, and it not interrupt your workflow?
Yeah, so we've had a very similar experience with my program as we've implemented this. It's taken some advanced planning of looking ahead at, say, our clinic schedule for the day, recognizing what it looks like visits are scheduled for, and identifying specific encounters that may be a good fit if we know that we want a knee exam evaluated, or we know that we have a certain history that may be more difficult of somebody coming in with undifferentiated symptoms. We would kind of plan with our preceptors ahead of time to come in the room to evaluate and observe those experiences. We've also found it really helpful for for patients that have to be seen by an attending anyway for billing purposes. That's a really great opportunity for that direct observation. Just grabbing them before we present the assessment and plan, or grabbing them before the end of that visit a little bit earlier than we typically would, allows them to do that few-minute direct observation to see pieces of it in a setting where they would already have to come staff that patient in person. Has been an easier way to not disrupt the flow too much. But it does take a little more advanced planning and just kind of open conversation with our attending so they know where we're at and where we need that observation.
Thank you for that perspective. The next question is, what about residents who are going to be board certified through the ACOFP and not ABFM? So this would be the osteopathic board. How does CBME fit for those residents? Will there be additional osteopathic competencies? So right now, this is just for ABFM, but ACGME is still requiring us to look at outcomes for all residents. So residency programs can make their own decision about what level they require for that board. But for ABFM, they have their own requirements about that. The osteopathic board does not have a requirement for outcomes yet, but they may be putting those together. And so that is a slightly different process, but it will be up to individual programs in terms of how that's used for graduation, separately than just board certification, which is after graduation. Next question. Are there plans for any standardized feedback forms designed to be easy, brief when possible, detailed when necessary, and ultimately able to be completed and viewed in a concise manner that isn't laborious? That is a well-written question. So I would say that the STFM task force direct observation assessment that's built into New Innovations and MedHub that was our attempt to create what you described. And I would refer you to the STFM CBME toolbox to access that, or you can just do it if you have New Innovations you can do it within New Innovations or MedHub as well. Maggie, what would you say are the advantages and disadvantages of that particular form that we put together?
I found that, so my program just started using it, and I found that's what's most beneficial of it is they tie the feedback to specific outcomes or specific things that they're observing. And so it's really quick and easy to pick one or two outcomes that they're observing, provide really detailed feedback in that moment without having to fill out an entire required form over every single competency or outcome. And so it allows them to provide really quick, succinct feedback over the one or two things maybe they observed in that encounter. And so it makes it easier for you to then look at it, remember what that encounter was about, and then directly apply that. And it's short enough that you can do it in the moment too, as that provider's walking back to the preceptor room or right after that clinic session. It's not something that's overly time intensive.
And these forms from both the resident and a faculty point of view, I think it's good to know that were designed so that for reporting purposes as well. So they're already mapped in the background. So as Maggie was talking about, the outcomes, the individual outcomes, you can run a report on those. And so if you do a bunch of those evals, then you have a really nice report to see how you're doing and what kind of progress you're making. Next question. You can also rely on your behavioral science faculty to do entire encounters. The PCOF form, patient-centered observation form, I think is what that stands for, is a good tool for more specific direct observation. And yes, that is an outstanding form. And I have nothing but have heard nothing but good things for it. The program that I'm affiliated with has used those. Have you ever used one of those forms, Maggie, in your program with the behavioral faculty?
Yeah, we found that something that's been really effective. We even will film encounters. So we'll bring like a GoPro into our room, which really helps with flow and not taking time away from faculty. And so then we'll review that with our behavioral faculty afterwards and work through that form together, which has been a really formative experience.
All right, can STFM help us get a quick list for procedures that are required for graduation and not have to wait 2 years for ABFM to do it? STFM would not want to do that because it really is going to be, it wouldn't hold any meaning because we can't create requirements at STFM. We're really just meant to help you enforce the requirements from other organizations and to give you the tools to do that. I would rely on what you're reporting currently when you're reporting in ads to programs. This would be for administrators and lead faculty. You already are putting a list of required procedures. So programs, I would highly encourage you to have your own list and then wait to make something that's more specific for ABFM rather than having another organization that doesn't know your program as well do that. Next question, how do you get the mobile app for feedback? So if you have New Innovations, you can download their mobile app already, the same for MedHub. So both of those companies have mobile apps, and then the evaluation form is accessible within that app, but your administrator would just have to set it up for you, and the instructions on how to do that are both in the task force website, and also both of the MedHub and New Innovations have detailed instructions embedded in their website as well. Hopefully that answers that question, and I'm very excited that people will use that tool because the task force worked really hard to put it together. So I don't see any more questions. Oh, wait, one more. Hey, we got 5 more minutes and we have another question. I'm not sure taking away 1650 was a great idea, as it was replaced by continuity requirements, which is more difficult to calculate without any guidance on how to calculate that. Maybe having a webinar for administration staff specifically for calculating the continuity numbers, or share web snapshots for EPIC or Cerner. And actually, there are some really great tools for doing that, and we can make sure that that's available on the website for programs. Additionally, the 1650, the continuity requirements, there's also 1,000-hour requirements that Maggie brought up. So residents have to have 1,000 hours in their continuity clinics. And the 1650, I am told they're still going to be looking at. No programs will get citations for not meeting it. Residents, unless the program wants to make that a requirement for graduation. Always remember that ACGME requirements are the bottom. That's just what you have. That's just the bar you have to get over. But great programs don't just meet the bar; they exceed it. And so, if your program is encouraging you to do more than the minimum required by ACGME, that's because your program really wants you to be the best, and that they're not trying to punish you in some way. So ACGME makes it very clear that they set the lowest bar they think is achievable by programs, but they want programs to surpass that where they can. And so they're going to be looking at the 1650, because if programs are not meeting continuity requirements, they're not meeting the 1,000 hours, but they are getting 1650, they may give you some grace on that. But programs won't get cited just for not meeting the 1650. And another one, will there be training materials provided, webinars, others for residents regarding how to effectively complete their ILP? Maggie, do you want to take that one?
Yeah, so on our toolkit, there is a section with a proposed ILP template that we felt as a task force kind of captured the core of what we want that ILP to include. Lots of programs have kind of taken that and built upon it and added in more based on what they felt was best for their residents. But there's a lot of great resources, including that template and some other links to educational materials for development of that ILP. So would encourage you to look in that toolkit.
And there was a webinar on ILPs. It was not specifically geared to residents, but was meant for both residents and faculty. And we would appreciate any feedback you have about if you think you need more information than what we have provided so far. And all of this is going to be continuing to grow as people use these tools, and we'll learn from your feedback and can improve them along the way. All right, with that, I think we'll end. Maggie, do you have any closing remarks otherwise?
I just think this is a really exciting time as a resident, and I think there's a lot of room for growth and just change in our educational experience where we get to be in the driver's seat a little bit more. So I'm excited to see what's to come.
Thank you so much. And thanks to everyone who participated, and hope we give you useful information. Bye-bye.